Happy Wednesday. Today is Wound Intelligence Wednesday, and today we're going to focus on a traumatic dressing selection. It's not just about comfort, it's also a limb salvage strategy. And in our diabetic patients, repeated adhesive trauma can create these micro injury cycles that eventually could behave like a cumulative tissue stress, okay, which would lead to something called epidermal skin stripping, okay, could cause a new ulcer or peri-wound breakdown. So just removing a dressing, because of most of human history, taking off a dressing often cause nearly as much tissue damage as the original wound itself. Sometimes everybody's different. Every wound care specialist is different, but sometimes I do like it to be a little bit of a like wet to dry sometime so that it could do some type of mechanical debridement on its own when I'm taking off the gauze. But everybody's different. But it's always good to have some type of debridement, right? And see some healthy bleeding tissue, but everybody's different because if it's too painful, then you're going to have to figure out better wound dressing, like an atraumatic one that would cause less pain. So imagine the wound is spending 3 days building granulation tissue only for about half of it to be stripped off with gauze. So, you have to remember how fragile these epithelial cells are, and they can get destroyed pretty much even during a dressing change. And so for decades, this has been happening. And they started asking a question, what if the dressing could stay attached without sticking to the wound, right? So this became one of the biggest revolutions in modern wound care. So we're happy about that. But what is the goal of it, the core principle of atraumatic, okay? Dressing changes. The goal is not just to cover the wound, but it also is to avoid creating a new wound during the dressing removal. So every dressing interaction has about 2 phases, application and removal, okay? And removal is where we find that you get most trauma, okay? So atraumatic care and dressing changes focus heavily on those 2 phases. So the dark ages of wound dressing, wounds used to be covered with linen, cotton, wool, animal skin, moss, honey-soaked cloth, and eventually medicine adopted cotton gauze, surgical sponges, dry dressings, right? Concept seems logical, but absorbs drainage, protect the wound, and change frequently. Simple, right? Except they had this problem. Some of the dressing bonded directly and pretty much incorporates itself into the wound. And that's something that I deal with, especially even with, venous stasis ulcers or nice beefy diabetic ulcer. Sometimes they really do stick. And sometimes people need non-adherent gauze, things like that, okay? So, who invented invented atraumatic dressing? So, in the 1960s, clinicians recognized we're damaging the wounds during treatment. Researchers started looking for materials that could adhere to the wound, avoid tissue stripping, and protect the fragile skin. And through that breakthrough, they came with silicone. Okay? So, as wound heals, they produce the fibrin, they produce the protein, they produce the exudate, they produce the blood products, and these dry into the fibers of the gauze. And the dressing essentially becomes glued into the wound bed. I'm pretty sure everybody knows about that. And when it's removed, the new capillaries tear. That's what we're seeing when we detach it, right? The granulation tissue sometimes attaches, and epithelium around the wound sometimes peels away. And pretty much you're starting the healing process again, but you're also kind of doing debridement. That's a little bit of mechanical removal of debridement, okay? So what is dressing trauma? Dressing trauma is any injury that is caused by the mechanical removal, the adhesive stripping, friction, shear, moisture-associated injuries, skin tearing. The damage may be invisible initially, but yet there is a cellular consequence that could be enormous for the patient. So the goal of our atraumatic dressings, a lot of our modern atraumatic dressings seek to preserve the keratinocytes, protect the granulation tissue, reduce the inflammation, prevent MMP activation, minimize the nociceptor stimulation. So why is our diabetic skin a high risk for adhesive injury? So in diabetes, of course, we already know the skin is already biologically fragile due to one, the glycation of the collagen, so it causes the stiffness and reduced elasticity. The xerosis, the dry skin, so that increases the friction coefficient. the microvascular disease that causes delay in repair of even the micro trauma, and the neuropathy, which is our protective feedback. And sometimes they don't feel it from the stripping or the pain of stripping, epidermal stripping. And even weak adhesive forces, there are weak adhesive forces called like van der Waals interactions. These could cause epidermal stripping, blistering, peri-wound extension, and new ulceration formation. Okay, that sound like a rhyme. So how do we assess a wound for this risk? Okay, so high risk patients for trauma like this is if they have the fragile peri-wound skin healing and it recently healed ulcers as well. Geriatric diabetic skin, edematous limbs, steroid exposed skin is quite fragile. Keep that in mind. Venous and diabetic ulcers that overlapped, the mixed wounds, they are also high risk, okay? But these patients require maximal atraumatic approach when it comes to that. Moderate risk are stable chronic wounds, moderate exudates, intact peri-wound, and then low risk are these wounds that have amazing robust skin integrity and low adhesion risk areas. So how do we choose it, right? The first line for a traumatic dressing is a silicone-based dressing. I love me a silicone-based dressing, but it has to be on the right one because sometimes, honestly, it can keep the infection in. I've seen it firsthand, okay? But silicone-based dressing, amazing, okay? So like silicone foam, silicone contact layers, how do they work? They have a low surface energy, there is minimal epidermal stripping, and it's a gentle peel force distribution, okay? These are best for fragile skin, painful dressing changes, post-healing protection, and peri-wound protection areas. Now, like I was mentioning, non-adherent gauze, there are non-adherent contact layer dressings like a petroleum-based gauze, a Teflon type dressing, low adherence mesh interfaces, and these work by creating a physical separation between the wound and the secondary dressing. So it helps reduce the shear during the removal of the dressing. And when to use that, you can use that for a moderate wound, but you still need a secondary absorbent layer, like an ABD pad, right? Now, soft silicone nets or interfaces, we did a little bit about that, but silicone is the first line, right? So, what is soft silicone? Soft silicone is this highly flexible polymer, and the polymer is simply a long chain of repeated molecules. And the important thing is its physical behavior. Soft silicone is quite flexible, smooth, comfortable, and actually hydrophobic. So, what does that mean, hydrophobic?
It means it dislikes water, and this characteristic is the key to everything. So, why does hydrophobicity matter? So, remember, a wound bed is quite wet, and diabetic ulcers contain exudate, water, proteins, enzymes, and blood products. And silicone does not want to bond with these moist structures. Instead, it preferentially interacts with the dry surfaces. And this creates a famous wound care paradox. Silicone adheres to intact dry skin while it avoids attaching to the moist wound tissue. So also you have to think about protecting the keratinocyte migration. So one of the most important effects involves the keratinocytes, and these are the ones that crawl across the wound surface, and their mission is to close the wound. And keratinocytes move only a few millimeters per day under the ideal conditions, but as we know in our diabetic patients, the movement becomes dramatically slower. And pretty much the silicone preserves this pathway, kind of protects it, and the keratinocytes can continue migrating uninterrupted, and this can help accelerate epithelialization. Now, another thing that the silicone does and help protect, right, non sticking to the wound bed, it protects the angiogenesis. So, angiogenesis, yes, is the new blood vessel formation. These vessels are incredibly delicate and these walls are thin and the attachment points are immature. So the structures bleed quite easily. So traumatic dressing removal can destroy these new capillaries. And the silicone helps keep them intact. And thus the oxygen delivery continues, the nutrient delivery continues, and the healing progresses. Another thing that it helps reduce the inflammatory cascade. So every time the tissue is injured, there's an inflammatory cascade that's going to go on, right? The body releases TNF alpha, IL-1, IL-6, the prostaglandin, and the matrix metalloproteinases. And these molecules are very elevated in diabetic ulcers. So the famous matrix metalloproteinase, these are one of the most important consequences when it comes to having traumatic dressing change, right? Because it does increase the MMPs. And the role of matrix metalloproteinases are these enzymes that digest proteins. Their normal role is quite beneficial, but they know when to turn off. But a lot of diabetic foot ulcers have excessive MMPs, and they destroy and remove dead collagen, damage extracellular matrix and cellular debris. But like I said, in a diabetic ulcer is quite excessive. And the increase, so trauma stimulates the inflammatory cells, right? And the inflammatory cells release MMP2, MMP8, MMP9. And these enzymes digest collagen, fibronectin, and the growth factor. So think of them as the demolition crew. And a few workers help remove damaged structures. An army of workers start demolishing healthy buildings, right? So this is exactly what's happening in our chronic wounds. And then also traumatic wounds can cause a little bit of growth factor destruction, right? Because excessive MMPs activities destroys the PDGF, the VEGF, the EGF, and the TGF beta. And these growth factors are quite essential for healing because without them, we can't have cell migration. There's no angiogenesis. The angiogenesis decreases and the fibroblast activities decreases. So, silicone disrupts this traumatic cycle by causing less trauma. And less trauma, what does less trauma mean? It means less cytokine release, less inflammation, and less tissue destruction. Another atraumatic dressing is hydrogel interfaces, okay? And these are in select cases. They work well with especially dry wounds, reepithelialized skin, and some painful exposed dermis, okay? So they reduce the adhesion, the friction, and the surface drying. But, we have to avoid or limit for our high risk diabetic skin anything that has acrylic adhesive dressing, absolutely not. High tack transparent films on fragile skin, absolutely not. If it's excessively dry gauze directly on the wound bed, unless it's necessary, like I said, I have my own method of working. Sometimes I like a little bit of mechanical debridement and some bleeding from the gauze stripping. Everybody's different. Everybody knows what they're doing, right? So, and repeated, like sometimes people use tape, right? On the skin that could actually hurt the skin and cause trauma as well. But in the end, we understand it. So let's a little bit understand the physics behind the removal of injury. Now, the more I learn about certain things, I understand why they made us take physics in bio pre-med. Now you're understanding, right? Yeah, because I was like, why am I learning about physics? I loved physics. I did well in it, actually. Yeah, it was, I loved it. It was fun. But okay, but physicists, people, they're extreme. They're genius. They're genius. They understand alien language pretty much because it's like the world of out. It's like I can't even know how to explain physics, but physics people are amazing. They're extremely intelligent in college. Well, you know what? I'm not going to go walk down memory lane. Let me finish. So, understanding the physics of removal injury. So, most stressing injury occurs due to surface energy adhesion, so the skin adhesive bond at microscopic level. Remember, I just mentioned van der Waals interaction. So, van der Waals interaction is this weak molecular attraction that becomes strong when the contact area is large. And then shear force during removal. So, peeling angle concentrates force at the epidermal junction. Okay. And the clinical implication of that is the faster the removal, I guess, less safer the dressing, in their opinion, some people. But a safe removal is at a low angle. I mean, it depends, low tension, supporting surrounding skin. I mean, if we have dry gauze on a wound bed, a lot of the times you have to wet it with whatever your dressing wetting thing of choice, right? Everybody has their methods. They'll not tell you try it. Everybody has their own methods. Whatever is more comfortable for the patient. That's my opinion because I'm not feeling it, right? So, what are some of our most common dressing atraumatic atraumatic dressings in diabetic food ulcers? I love Mepitel. It feels so good. It feels great in your hand. Mepitel is a classic silicone contact layer. It's extremely popular. You can place it directly on the wounds, and a secondary dressing is applied over it. Mepilex Border is also another common one. It has silicone and foam absorption. To each his own. Use everybody's different. The wound care specialist knows what to use on it. Okay. Mepilex Light is for low draining wounds. There's Mepilex Transfer, useful for heavy exudative wounds, transfers the fluid into the secondary dressing. Adaptic Touch, that is really excellent for exposed structures. Urgotul, okay, we just spell that Urgotul. That is a lipid colloid technology, another atraumatic option, widely used internationally, actually. And silicone foam dressings, here's the thing. I had one incident. I used a silicone foam dressing on a patient who had a diabetic ulcer, and it was only like a 2-day dressing. Next dressing change, yeah, it turned left. Okay, I think it was too occlusive for it. It trapped too much moisture, and yeah, I had to start from zero again because it trapped so much moisture. Like when we took off the atraumatic dressing, there was so much mucus and exudate that was just sitting in there. Yeah, I said never again for that patient. Yeah, I learned my lesson. When things like that happen, explain to the patient what's happening, say what we're gonna do. Let's give it to a day because if something goes left, I need to see you back the very next day. That's the truth. But yeah, that was my experience. I learned that you have dressing selection is quite important, extremely imperative and quite important, and it can turn a wound left or right. We want to turn right, right? So it can heal. But picking the wrong wound dressing can be, let's say dire, but can cause more harm than good. Okay. So you can't just slap on anything on a wound. Okay. So, what are some of the cellular effects of an atraumatic dressing? Fibroblasts survive, the keratinocytes get to migrate, the growth factors remain intact, the VEGF signaling continues, the capillary buds survive, extracellular matrix remains stable, and the wound remains in a nice healing state. Now, another beautiful thing about atraumatic dressings, because I won't say traumatic, but it's atraumatic dressing changes, is the pain reduction. Pain reduction is one of the biggest advantages because why? Traditional dressing changes can activate the nociceptors, substance P, and inflammatory neuropeptides. And the repeated pain can cause this anticipating anxiety for the patient, unfortunately, and patients begin fearing dressing changes. I've had some incidents like that too. And yeah, you try to get them not to. Sometimes you have to pre-medicate, and but the beautiful thing, absolutely beautiful thing is when they keep on closing, the wound becomes less and less painful. But another surprising thing is sometimes their sensation returns and they're like, "I can feel it," and I'm like, "Oh, wow, that's awesome." And plus you're getting your blood sugar down. But atraumatic dressings dramatically help decrease pain, okay? And now another thing like we have to think about is the peri-wound protection strategy, which is quite critical in our diabetic foot care. Use a barrier protection. Like I said, I like to use zinc, right? Zinc-based protective ones are very useful in maceration, skin sealants. Some people use silicone barrier films. To each his own, okay? But it helps reduce the skin stripping risk, the micro tears during removal, and the adhesion forces. And make sure you match the dressing with the exudate level. Remember, like high exudate, they recommend foam or silicone interface, alginate with a non-adherent layer. Moderate exudate, they like to use silicone foam dressing, a contact layer, or a secondary absorbent. And low exudate, silicone or a hydrogel interface. It depends, okay? But the wound care specialist knows exactly what to use because every wound has its own, absolutely own personality. Not one wound is alike, especially diabetic ulcers. They all have their own personality. They take on the personality of their owners, the person who the wound is on, daily habits, as well as if they have any vitamin deficiencies, their activity levels, their stress levels, it takes on everything. So everybody, as we know, every person in this world is quite different. So every diabetic ulcer is very, very different. There is never a one size fits all. And that's what a lot of people who are just getting into wound care or just don't really understand about that with wound cares. There is absolutely no one size fits all. There may be a good criteria line, borderline, but what you're going to learn as you get more experience, every wound is different and they all have their own personalities. And you might be like, oh, this is supposed to be for this wound, and that wound does not like it at all. Okay, so you got to learn. Okay. So, what are some red flags that you're using the wrong dressing? Skin tearing, you get everybody, you'll be able to see it. Okay, it looks like torn paper if you're tearing the skin during the removal. Okay, a stuck dressing syndrome, like the patient doesn't want to get it off, like they're scared of it, the fear, the avoidance of the dressing change. I remember when I had surgery and I had to do post op massages or something like that. I avoided that person like the plague because it was so extremely painful. And I have a very high pain tolerance. I think I have extremely high pain tolerance. I had no pain during pri- giving birth. I actually didn't. And yeah, I don't remember it. And I have quite a good amount of piercing tattoos. But that post-op massages, I ran like the plague. I used to act like I couldn't go. I used to act like I couldn't sleep. It was extremely painful. And the doctor, of course, one thing about me, I do not take any opioids even after surgery. It was extremely painful. I did not take opioids because I'm too scared. But I was in so much pain. I had to take Tylenol and ibuprofen, but I didn't take any opioids. I was just too scared. I didn't know what was going to happen to me. I know the whole physiology behind it, but I just know that my body's quite sensitive to things like that. I've never taken one, but I just know my body is quite sensitive, so I just didn't. But the pain from the post-op was painful, and yeah, I avoided that person like the plague, the person who was supposed to take care of me post-op and everything. Yeah, because it was so painful. So I completely understand why patients would avoid coming and following up because it's so painful. So that is something that we definitely have to address, okay? And remember, frequency of the dressing changes actually matters quite often. It's kind of like a date. You have to say 3 times a week, 4 times a week, 5 times a week, or every day, every other day, you know? But even the best dressings can become harmful if it's left on too long, okay? If it's changed too frequently, that's another thing. You learn that wounds have their when they know when they need to follow up with you, okay? You like sometimes I remember because sometimes dressing a wound too frequently does impair the healing as well. Because I remember this one time I had to not see the patient, and they were just like, "Okay, I'll just keep the dressing on and whatever." And they just wanted to keep the dressing on. They didn't want to see anybody else, so they just waited till I came back, which is a week, and made sure the dressing was good or whatever. But when I saw it, I was like, "Oh wow, this is dramatically much better. This is a dramatically good amount of new skin." And so I said, "You know what? Let's try once a week." And yeah, it liked once a week. I do love to keep a close eye on my wounds, but if a wound does much better with like 4 times every 4 days or every 5 days or whatever, or weekly. I remember I had a wound that had bilateral wounds, and one could only be liked being changed weekly, and one loved being changed twice a week or 3 times a week. And if it didn't get changed twice a week, it would behave badly, it would get infected, it would be like, "You're neglecting me." And the other wound on the other side, once a week, perfect, beautiful, clothes perfectly. So it's always each of them have their own personality. But you know what clinical insight is like? What are the indications for atraumatic wounds? We're mostly focusing on our diabetic ulcers, right? But the selection is about avoiding adhesions, right? And controlling how the molecular forces interact with a fragile diabetic skin. But every dressing has to have a balance between fluid control, infection, and protection, okay? So, what are some of the indications of atraumatic dressings? They are excellent for diabetic ulcers, venous ulcers, arterial ulcers. It depends. The wound care specialist will know. Post-surgical wounds, grafts. We use a lot of Mepitelon grafts, epidermolysis bullosa. I know I'm not pronouncing that well. Pediatric wounds, radiation injuries, donor site injuries. These are, so people know when to use it. What are the contraindications? That's the biggest thing, right? Atraumatic does not mean appropriate for everyone. Okay, so avoid relying solely on them. If there is a severely infected wound that requires aggressive management, yeah, we cannot do atraumatic at that time. Okay, necrotic tissue that dominates the wound bed, absolutely not. Dressing purpose is needs active debridement. then due to debridement per vascular assessment and clearance. Massive exudate is seized dressing capacity. You got to change the dressing. You got to figure out a different one for the patient. Advanced surgical intervention is needed. We already know that. Common sense is common. Okay? But, let's just make common sense common and listen to the patient. The patient knows how they feel, what works best for them. And you know what? Atraumatic dressings are quite economically friendly. The cost is quite upfront. Studies have showed there are fewer complications, faster healing, less pain, reduced nursing time, and fewer dressing changes. Okay? And so, what is the future of atraumatic technology? They might have soft silicone dressings that have growth factors, sensors, oxygen delivery, drug release systems, and AI guided wound monitoring. But the final teaching point is that in diabetic wound care, we're often focused on what's happening inside the wound, like bacteria, ischemia, inflammation. But one of the most important causes that could be prevented is mechanical failure of the skin during dressing change removal. And that means dressing is not just a barrier, but it is a biomechanical interface. Okay. So we have to choose the right one on the right limb. Okay. Because in diabetic foot ulcers, it often depends on it, okay? Like the health of that diabetic also depends on our wound dressing, okay? And atraumatic dressings did not heal the wound by adding something to it. They help heal the wound by stopping us from damaging it, okay? So we have to recognize that profound truth that every dressing change is a biological event that's happening in that wound. Every removal either supports the healing or sabotages the healing. And in diabetic ulcers, where healing is already compromised, preserving the fragile skin, especially around it, can mean the difference between closure and chronicity, limb salvage, amputation, recovery, and recurrence. Okay. And so next time we remove the dressing, remember the wound is watching, it's seeing how well you're nice to it. And sometimes the most powerful treatment is doing less harm. Okay. So keep that in mind. And this is Dr. G and Diabetic Foot Files. Happy hump day again. And yeah, take care of your feet because they take care of you.